Hello, everybody, and welcome in. I think um, folks are going to trickle in for a couple of minutes. We're glad you guys can join us and are all ears to learn a little bit more specifics about ABA codes. Hi, Sarah Shinley. I see a familiar name right there.
Hello.
Yeah, look at all this Washoe representation. Okay, Erica, what do you think? I think some of the trickling has slowed down a little bit. You want me to go ahead
Yeah,
and
it
get
looks like
started or want to do one more minute?
I think you're good to go.
Okay. Um, okay, everybody. We are so glad you're here. I know that one of the big kind of messages you've probably heard floating around from like state partners and so forth is um, the allocation of provider type 60, which allows for services, the provision of services in schools to happen kind of in relation, provided, memorandum of understanding or inside of like with their school-based providers. Just allow for the possibility of additional funds to float into schools if the appropriate services are provided, billed correctly and documented correctly. So our wonderful Erica and partners at the state had previously put together a codes crosswalk related to familiar types of providers who often facilitate opportunities for additional skills-based instruction or interventions in schools. And then we've been waiting to deliver kind of a crosswalk of codes to you guys related to ABA therapy as kind of a separate asking, just given kind of the number of codes that apply to us in the world of applied behavior analysis. So this is a really casual setting, and it's an introduction of our 8 CPT codes. And I see familiar names on this call who I am like sure are also familiar with these codes. And so ideally what we want to do is after the presentation of these slides, just open it up for Q&A and really amongst those of you guys who are in schools to really facilitate conversation about how these do translate into the school setting. Because hear me say that I understand that it can look different for you guys, and we need to always take into consideration FAPE and how we pull students for time away in order to provide these. And so this is for informational purposes and just to kind of help facilitate that conversation and lead to possible next steps. Um, and so what CPT codes refer to are those standard set of billing codes that allow behavior analysts to document what we're doing with students or with individuals. And the range of codes that we most frequently use are those that range starting at 97151 for assessment, all the way up to 97158. And all of these codes are used to document the different areas of service that we provide. So depending on what we are doing with that individual or the level of service, we have to document it using those different codes. And we're going to talk about each of those individually. Most of these codes, with the exception of the family guidance codes, are billed in 15-minute increments. And that's just important to note because sometimes there are certain service codes, maybe perhaps inside of other professions where, contact with an individual might allow for billing, or if other codes are billed in 60-minute increments and so forth. It's just important to know that when services are billed in 15-minute units, that means that we have to be providing that level of service for the bulk of those 15 minutes. So if we see a client and we decide inside of like 2 or 3 minutes that we're going to update a goal or change something, that cannot count, right? So the bulk of 15 minutes. So inside of at least like 8 to 10 minutes have to be spent inside of kind of that billable service that we're providing in order for it to be ethically and legally billable as that code. And CPT codes matter when we are seeking reimbursement and billing and additional funds, because it helps ensure that what we are putting out billing for and getting reimbursement from are in alignment with what we're suggesting and saying that we're doing. It helps standardize that communication with the funders of record. So in this case, especially with the Nevada Health Authority, or formerly Nevada Medicaid, just kind of standardizes what they know that they're looking for when we say that this is the service code that we're providing. It reflects the precise type and the intensity level of the services that we're providing. And then it's just, supports that compliance, the documentation requirements that are standard of practice for high quality service provision. So we have multiple code categories that we work with in applied behavior analysis. A really important one is that assessment code, so we'll talk about that specifically in a minute on the next slide, 97151. And kind of my biggest message, just as a behavior analyst who formerly comes from the private world, and we're kind of dipping our toes into how or if and when we can provide these services in schools, is that this code is really necessary, right? So we cannot provide any of the other codes that we can engage in. We can't start that individualized one-to-one treatment if we haven't first assessed and developed a treatment plan that lines up those treatment goals inside of a documented plan of service. And these are those assessment codes, right? So 97151. That's our behavior identification assessment. This is basically how we are going to conduct an analysis of the behaviors that we are looking at, either inside of skill building or behaviors of concern reduction, right? So this includes any assessment we do, including a functional assessment, any data analysis, a skill building assessment. So if we want to if there's an opportunity to pull a student aside for some individualized skill building, utilizing the PEAK, or here, insert your favorite assessment here. So, PEAK, VB-MAP, Vineland, all of these things. And this does need to be conducted first. We generate a report. It suggests that any services provided under like further behavior codes are in fact tied to the treatment plan. And guess I just am spending kind of an extra time on that 97151 because, I've, heard some misnomers related to that one, like we don't do 97151. That's for a multidisciplinary team to engage with, and then they tell us that we're supposed to engage in one-to-one treatment, and that can be possible, right? It might be that we maybe are not participating in that multidisciplinary team meeting. However, if we are asked by an MDT to engage in individual treatment or group treatment, facilitate any of our other codes, we then as behavior analysts have a responsibility to go in and conduct our own assessment. And the other providers and professionals on that multidisciplinary team have their own codes, right, in order to participate on that meeting. So this is not a meeting code, this is an assessment code. Same with 97152. Really, those are both assessment codes that identify who usually is delivering those services. So 97151 is typically delivered by behavior analysts, so BCBAs, BCABAs, and sometimes we ask a technician level staff to help us out, collect data, deliver some skill building assessments, right? And so if that's the case, then they will use 97152 under the direction of that BCBA or other qualified healthcare professional. Oh my goodness, I forgot to make a slide about the modifiers, and I think I meant to. But if we use a code that is typically identified for a different provider type, we can, and we just have to add that modifier. And we can talk about that more at the end. I'll quick make a slide for us. And so these are direct treatment codes when either that one-to-one or a small group behavior treatment are delivered. Most frequently, these codes are utilized by technician level staff for that one-to-one kind of therapy or instructional level of support, delivered by, often that registered behavior technician. And then if, a technician level staff has been asked to engage in a small group, perhaps like for delivering a social skills group or something, and there are anywhere from 2 up to a max of 8 clients, then they would utilize 97154. And so those are going to be structured, again, with those goals tying back to individual students' treatment plans. Supervision and protocol modification. This one, 97155, is really important to understand that protocol modification is a necessary requisite of engaging and billing for this code. We can't ask our funding sources, insurance companies, Nevada Health Authority to pay for our professional development, right? So simply this is not simply just an observation code. We're not observing a one-to-one session simply to make that behavior technician better or improved, right? We are supervising this session with the intention to update those goals as identified in that treatment plan, update programs. So providing technician direction is absolutely a part of this code, but again, with the intention that we're modifying and making those, like the intention of those goals better and those programs different, making treatment adjustments, those ongoing clinical decision-making skills, right? That's the purpose of this code. Again, not to be confused with, professional development and just the observation and supervision of that technician as defined. So I think sometimes there's a little bit of a wondering or a kind of miscommunication about what this one means. This is, could facilitate an interesting conversation because in ABA, we do have 2 codes related to family guidance. One of them, 97156, is related to individual parent or caregiver training. We probably automatically maybe put up some walls like, oh, we can't, or how does this, facilitate inside of a school? So again, looking forward to further conversation. However, I think where there might be opportunities could be inside of 97157, inside if there's instruction related to a behavior protocol, perhaps that could be related or delivered in a school setting to a group of multiple families. I do see some possibilities there. And again, just kind of some notes that these can be delivered in the absence of the student being present. And so similar to where we just saw those treatment codes for technician level staff at 97154, if a BCBA or BCABA is delivering kind of a group-based treatment, small group setting, 2 to 8 students, we should bill 97158, and that includes, again, kind of similar to if we're providing that 5-5. During that group, in addition to facilitating, we might be making some real-time kind of adjustments to that treatment during our delivery of that group setting. So again, just to kind of sum up, what we did is just a reminder that most of these codes, with the exception of those family guidance codes, you can bill for 1 hour at a time. So kind of planning for those 60-minute increments when delivering kind of some instruction surrounding family guidance. Everything else is billed in those 15-minute increments. So if we have a family guidance teaching session that's 45 minutes, right, that would be, acceptable billing for 3 units. Same thing if we, but however, if we are, if we engage in a family guidance with a group that's 35 minutes, that would count towards that 30-minute session, not a 45-minute session. So really just being careful about the number of minutes and the units that we're billing, just to ensure that we're providing those accurate billing, and we are in compliance with the codes, in the case of audits and so forth. I think, the last thing that I wanted to make sure that's really important is something, Erica, and there's other experts on this call that can speak to PT60 more broadly. And of course, we don't have to seek prior authorization in order to engage in 97151 and so forth, in order to begin this for the students in our care. However, our inside our these codes tied to ABA, we are, as a group of professionals, still tied to specific diagnoses. And so it is necessary that we fill out and turn in the FA11F, is my understanding, just so that we ensure that we are allowed to bill for the work we're doing with that student or those groups of students. And so just wanted to make sure that we stay in compliance with that. With that, I'm going to stop sharing my screen for a minute so that we can open it up to, I know we have Dana on this call, and she has a breadth of knowledge surrounding like PT60 in general. I see familiar names in terms of like behavior analysts on here. So I'd love to open it up to questions, comments, wonderings. See what's in the chat.
Hey Megan, Bobby here.
Hey, Bobby.
Quick question. With the FT11, one question we had, that's a medical diagnosis, correct? Not a educational diagnosis?
Correct. So this is where I'm going to probably tag in Erica and Dana if you're on the call too. I just see a whole bunch of Hollywood squares. But yes, the FA11 is the medical diagnosis. So it's suggesting that this And because right now, as far as like everything that I know, like behavior analysts still can only work with autism diagnoses, FASD, sometimes Down syndrome, right? So we just have to show that we're working with providers, or I mean that with students with the appropriate diagnosis.
Hi,
Trying
Megan.
to get
It's
rid of that.
Monica with Nevada Health Authority. So I
Hi,
will
Monica.
chime in on that as well. For reimbursement through Nevada Medicaid, yes, it does have to be medical diagnoses.
Hey, it's Sarah. I have a question. Um, for the treatment plan, when you're talking about that, would it be a separate treatment plan or would those be then the IEP goals under, do we know what that would look like? Kind of.
Yeah, I think so. Because the work that perhaps like a technician in the schools might be doing if they're addressing some specific behavior goals, you know, the idea behind this is perhaps that they can bill beyond those services in the IEP. And so there does need to be a treatment plan that is, you know, aligned with those goals. And if it's, you know, pulled out of the IEP or a part of the IEP, I think that's kind of up for like individual, but also that I think this was, I mean, it's hard inside of ABA because we're tied to specific diagnoses. So chances are all of our students are going to have IEPs. But also the purpose of PT60 as a full umbrella was to also allow for services to be billed for even for students who do not have an IEP process.
Okay, thank you.
Nancy Brooks, I see your hand is raised.
Hi, everybody. I'm Nancy. I am the Medicaid coordinator down in Clark County School District. And just wanted to let you all know we have been billing for ABA since February of 2024. We are using 3 of the codes that Megan went over. So I would say if you have any questions, you can reach out to us and we are happy to assist.
It's wonderful. Thanks, Nancy. Do you mind sharing which 3 codes you guys have been successful in providing services for in Clark County?
Sure. We are using 97151, 97153, and 97155.
Perfect. Those are like the 3 I would expect, and I'm so happy to hear the 97151 because the reason why I just put that little soapbox in at the beginning is because we got close to a district just rolling right out of the gate with 97153 without tying it to that 51, and that's where we could flip on our heads a little bit.
Yeah, and to answer some of the questions that other people asked, all of the students that we are providing and billing for do have an IEP, and so it is tied to their goals in their IEP.
Nancy, have you been billing outside of IEP or most primarily with IEP plans of care?
All of our students that receive ABA in the schools all have an IEP.
Okay, so that's the most common,
Yeah.
really.
Yeah,
Yes.
I think Dana, because right now, like just as long as those codes are tied to specific diagnoses, it's mostly going to be continued billing inside of IEP services.
Especially since it's a medical diagnosis, not the educational diagnosis, which gives us that additional layer or red tape that we have to go through. That was the biggest struggle that we had to overcome, and we're still overcoming in our district.
Yeah, like getting that the FA11 F form kind of filled out and kind of as proof that we can get these services started.
Well, we
And I
provide the
have to give a
services no
shout
matter
out.
what.
Sorry, Sharon.
So
Yeah, exactly.
Yeah.
Can
But
you
getting
bill for them?
reimbursed.
Right.
And I need to give a shout out to Caesar, who he's on this call and I'm shouting him out. But Caesar is our director of our ABA department, and he and his BCBAs have been working so hard at getting those medical diagnoses from parents. And so we were able to increase the students with an FA11F. I want to say we started really honing down on this process in January. And I want to say we got like 90 FA11F signed. No, of course, not all of those students are Medicaid eligible, and not all of those students have consent. So we're not billing for all of them, but his team has worked so hard with our office in getting those FA11F signed and processed, so we are able to bill for those students if they meet all of the other billing parameters.
Yeah, so like it's somebody's nearly a large percentage of his FTE is spent chasing those down. And there's probably a common thread of professionals that are on here that yes, chasing down consent and in that likelihood, the FA11 is kind of like the big first hurdle and speed bump. I hear that. What's going on in Washoe County? What are you guys up to?
So I had a quick question for Nancy. Or Caesar, you can pop in. Are your BCBAs providing direct services to those clients? And is it written in the IEP that way?
Not the BCBAs, the RBTs are providing direct services. The BCBAs are the ones that are doing the assessments and then participating in the IEP to help write the goals that we're going to be connected to.
And so Clark County has hired and you guys have RBTs on staff employed through Clark County School District.
Correct.
And are your BCBAs providing their supervision?
Yes. Yep. And I have to give a shout out back to Nancy and Sharon because they have both been amazing at guiding my team throughout this whole process. So appreciate you both.
One more quick question. How many BCBAs and RBTs do you have on staff, if you don't mind sharing?
I currently have 5 BCBAs and 32 RBTs.
Bobby, how many BCBAs are in Washoe County now?
We currently have 5, but I think we're going to be getting some more soon, hopefully.
Yeah. And you guys have not chosen to go to hire RBTs and train RBTs yet? Is that right?
I can try to answer that. We have some RBTs on staff, but they're not necessarily tied directly to students.
Got it.
Yeah. So I guess that's a question is, are those RBTs tied directly to students and working with them all day long? Or are they sort of floating between schools? What does that look like?
They're floating across schools, so they're not connected. I mean, they are kind of connected to students, but at any time we could switch RBTs up depending on the need. If we need to switch them around, but they each have their own individual caseload that they service.
Oh, yeah, Bobby, this has come up before from you guys too, I think. So these guys, they're district RBTs. They're not necessarily hired by the school. They're not school, which allows them to travel between schools. And I think that was a wondering before. Okay.
Yeah, that's the same
Thanks,
with
Nancy.
Clark. They're more itinerant, as opposed to assigned to any one individual school.
And they're not like a one-on-one aid where they're with a student all day.
And so that was what I was going to ask, kind of follow up with that. So they're not acting as a one-to-one aid. About on average, and how many hours is one student maybe getting of RBT time? Like, is it kind of set, like where they have 5 hours a week with an RBT? Like, is it kind of set up like that, or is it vary?
Currently, we have students receiving either 45 minutes a day, and some get up to an hour as well.
Okay.
Is that time that you're pulling them out of the classroom to work on the goals related to your assessments, or are you working on classroom goals during that time?
It's whatever goals we're connected to in the IEP, and we typically start out our services doing pullout, but then midway towards the end, when we're getting ready to potentially fade out our service, then we start working in the classroom to start to work on generalization.
One more question about that. So would you say that the goals are a lot of skill acquisition, or is it more of behavior reduction, or is it a mix?
It's a mix, but the majority of them are mostly learning to learn skills. So we're working on
Okay.
responding, attending, and we do targets like frustration tolerance and some other skills that our students struggle with.
Sarah, these are really great questions. And Bobby.
Thank you. It's been a long time since I've been in the clinical world, so trying to think of how billing would look and how that service model would look within a school district, and then kind of how we currently are functioning is, I just have a lot of questions. So thank you for answering them, Cesar and Nancy. I'd really appreciate it. Sharon.
Hey, Caesar, this is Lindsay Kendrick. Do your RBTs work with just students with IEPs, or do they work in general ed settings as well?
No, they need to have an IEP.
Okay, thank you.
You're welcome.
I'm curious,
So-
Caesar, did you hear anything of that we're missing for billing? Because I missed the first couple minutes. So that's what I was interested in is, are we maximizing every opportunity to bill? Because there's a ton of stuff that our BCBAs are doing that we would hope we could bill for, but I don't know if we found a way through the logistics. So did you hear anything, Caesar?
I definitely took notes on the group adaptive behavior treatment part, because we're bringing back a social club opportunity that our district used to have for students previously, and those sessions are going to be done they're going to be done during the summer, and they're going to be ran by RBTs and supervised by BCBAs. So I'm thinking, how could we potentially um, bill for those services, and what would the service plan look like? Could it be just the student having an IEP and having deficits in social communication skills, along with goals tied to those deficit areas? So just I'm trying to think of how we could potentially bill for the service that we're gonna bring back this summer.
I had one more question for you guys. I'm not sure how your referral process looks, or how a team requesting for extra help might get those behavioral services. But when they are requested, do you guys prioritize billable clients over non-billable clients in terms of the RBT and BCB support that you're able to provide them?
No, no, we do not. We take the students, and obviously there's a referral process, which includes an assessment as well. But we don't prioritize students that have the eligibility and the consent and all of that.
So you have RBTs and BCBs working on non-billable clients as well?
Yes.
Thank you. I just want to make sure I just checking in.
Doesn't mean you couldn't be a little strategic with that, but absolutely you would never prioritize one over the other. But you could potentially be more strategic in the fact that how those are assigned to the different staff providing those services, but no, never one over the other.
Yeah, that's a really good question because, of course, I mean, you guys are the first to know that like we can't. You guys in a school setting have to provide these services as students are referred to you, no matter what. And so I think that's probably one of the behind the scenes things that has to happen is, policy that says, I mean, perhaps, the BCBAs or the RBTs don't even necessarily know if the student they're working with is, a billable student or whatnot. That's kind of takes place behind the scenes because you guys are providing those services no matter what. And then, kind of hopefully, possibly able to get some reimbursement for some of those services that are being provided.
Yeah, unfortunately, we don't, we're not able, it's not self-sustaining. The reimbursement that we receive versus the amount of services that are provided is not self-sustaining or even close to it, unfortunately.
Yeah, these are great.
Is there any opportunity for, I may have missed it, FBA for conducting an FBA and writing a FBA and a behavior intervention plan?
Like you mean billing for that service?
Yeah.
Yeah, and Nancy did speak to that. So that's what the 97151 code is used for. So FBAs, like assessing a student's needs, insofar as FBAs generating that report can all be captured under 97151 if it's done by a BCBA.
But that's not what we're currently billing, right, Nancy? We're not billing for the FBA BIP, we're billing for the actual assessments that are being done, not the FBA or BIP, right?
Yes,
It's kind of
but
all
I'm
lumped
wondering,
together.
Yeah,
but I'm
because an
wondering
FBA
too.
Go ahead,
can be
Caesar.
part of that.
I was just gonna
Caesar.
say, because I'm wondering, because we do sometimes get involved with assisting with conducting functional behavior assessments, so I'm wondering that as well now. It doesn't happen as often, obviously, as our IIS assessments, individual intervention services assessments, but we do at times provide support with FBAs as well as behavior plans.
And we don't bill for those,
Correct.
correct? Yeah, so I'm wondering if we could think outside the box on that one, how we could potentially, if it could fall under that code, how could we make sure that we're meeting all the requirements and potentially get some reimbursement for that? If that
Yeah,
is considered an assessment.
Because under a comprehensive set of assessments, that opportunities for behavior reduction might be, inside of those replacement skills or those skill building skills. So absolutely, that can be captured. Naomi, I see your hand up.
Hi, can you guys hear me?
Yep.
Okay, I just had a question along those lines, and you said that, correct me if I'm wrong, that the FA11F form doesn't need to be gathered for that 91, the code you guys were just talking about for the FBAs.
No, it does, because all of these codes, all ABA codes are tied to specific diagnoses, and so that's
Okay.
for lack of a better phrase, like it's the proof of medical diagnosis that behavior analysts are working with.
Okay, so
those specific diagnoses.
They're required to have the FA11F form for all the codes.
Mhm.
Okay, perfect, thank you.
Sarah?
Yes, I just want to, it's been a long time since I billed, so I'm trying to remember. For the 151, the assessment code, that is a 4-hour maximum every 180 days, correct? Like we can only bill for 4 hours? Do we know?
Oh, Erica, can you speak to that? I don't believe that it was a 4-hour max. That was because in my private world, I feel like I asked for my units of that, and it was usually like 8 to 12 every 180 days. But now that I'm 3 years outside of billing,
This is Erica.
I'll get back
I
to
can
you.
look into that real quick and get back to you guys as you continue
Okay,
conversating.
thank you. Yeah, it's been almost 10 years since I billed, so I'm trying to remember what those maximums and those allotments were.
No, I think 4 seems like a pretty low ceiling at that point. That might have been initially like when billing was first mandated. Like I can't think of a comprehensive assessment I ever did that was only 4 hours.
No, and that's what I was thinking. I was like, all these assessments can take a long time, and so I was just trying to remember what those parameters around those codes were.
Okay. Any other wonderings? Well, Erica from Nevada Health Authority double checks us.
Megan, will we have access to this recording?
Yes,
Awesome.
the recording is going to Erica, and I think she intended on sharing it with folks.
Awesome, thank you.
And we're gonna
Yes,
send
we
out
will
those
be
slides.
posting. Sorry, there's a delay on the audio from my end. I didn't mean to interrupt. But yeah, we'll be posting the slides, any supportive materials, and the video recording.
I had one more quick question for the folks out there in Clark County. I'm not sure how much advocates are involved in your work, but I'm sure it's similar to here in Nevada or Reno too. Are your advocates currently requesting / demanding that BCBA or ABA time be written into your students' IEPs as a related service? And if so, what does that look like?
Yes, we do get requests from advocates, as well as parents. And we just inform them that we have established a process that includes an assessment, and we follow the same process no matter whether it's a request being submitted by a school team or a parent or an advocate. But we do get quite a bit of requests from advocates.
So are you being written into those IEPs?
Not without our participation. So we attend the IEPs and we go over our assessment results and give our recommendation. And obviously it's an IEP team decision, but we strongly encourage IEP teams to make decisions that are based on data, which includes our assessment results. So that's not to
But
say
yes,
that they, oh, go ahead. Sure.
I'm sorry to interrupt, Caesar, but yes, we have to write it into the IEP because we have to have a plan of care, but not necessarily as a related service. So we are strategically writing those into the IEP, as Caesar said, after their team participates and does the assessment and says, yes, they should be written in.
Correct.
Yeah, and I think that's a really good point of discussion too, is that, yeah, if, you know, advocates or parents or whomever is kind of asking for, demanding, to use those words, I think that it's really important to then to start at that level of assessment and then say, well, you know, because you want to be written in at the level that's appropriate for that student, and not be like, surprise, your team is providing 97153. Because, you know, you need those data to back it up and then to be tied to your treatment plan, not, you know, something else or a generic one. Nancy.
So I had my hand raised because when you brought up the word advocate, I totally thought you were going to go somewhere else. So I just kind of wanted to share, you know, one of our biggest things with advocates is that a lot of times they will advise the parents not to sign the consent form, consent to release, consent for billing, because they think that it will take away from their community benefits, which is an understandable concern, but it's a misconception. So last week or the week before, I can't remember, but I presented to, it's called the SPED Alliance in our district, and it's parents that come, but also a lot of advocates. And I created a slideshow and I showed, no, it's 2 buckets of money, this, that, the other thing. So we're hoping that those advocates that were in attendance will take that information back to their families that they represent and their groups and their newsletters and all of that, because that is, at least from the billing side, you know, Caesar talked about the advocates from the service side, but from the billing side, that is one of the biggest hurdles that we are trying to overcome, specifically with the ABA community. Of course, there's still, you know, parents with speech and OT and all that they think it's going to take away from their community benefits, but ABA is definitely like the loudest, most vocal about that. So we are hoping that with our outreach and our messaging that those myths are busted and the parents are understanding that it is not going to affect their outside benefits.
Yeah, I agree. And I think that's been probably one of the biggest themes for years now too. And so kind of the importance of like the understanding of that like PT 60 umbrella that is protecting those benefits outside of the school setting for community providers. So that actually suggests, yeah, like the need for awareness trainings for our partners, like partnering advocacy agents and so forth.
Megan and Nancy, this is Monica. I threw it in the chat, but I think this is such an important topic because it has been happening and being talked about since I started in school health services. And so one of the things, as you folks know, we're going into our last year of our grant for school health services. And one of the things we're hoping to do this year, because we have done a lot of the things we've set out to do, is look at some education, both for families and, you know, communities, but also we should also be looking at the providers and just helping them understand that as well, because sometimes that's where our families are getting that information that confuses them. So just to put that out there for y'all, that is something we're looking at this year.
Thank you. Any other wonderings while we have the good of groups or in schools on the call together with us?
I do,
We'll get
if you don't mind. Just I
Please.
want to follow up a little bit on Bobby's question, Caesar, with the so you said that they aren't necessarily written in as a related service. How are the RBT and BCBA then documented into the IEP as providing that service?
So currently we write it in as a supplementary aids and services.
Okay, thank you.
You're welcome.
And it's documented in the service is documented in our Easy Track system.
Yes, as well as now Infinite Campus, which is nice.
Okay, you guys. We'll make sure that those resources are posted for you very soon, so you guys can refer back to them whenever you need. And if you guys do have any questions or need to be kind of connected with anybody, please don't hesitate to reach out. And thank you for hopping on today and being willing to kind of stretch the usual of what's provided in schools and help our students.
Thank you, Megan.
Bye, Bobby. Good to see you.
This was awesome, guys.
Thank
Thank you
you.
so
It
much.
was really good. Thank you, Megan.
We
We want
appreciate
this
you,
for
Tara
all
and
the
Nancy.
other services, Monica, because this was fantastic. We got the exact codes, what we could look at for billing, and so that's exactly what schools need, I think. And then the
Okay.
opportunity to share ideas and bounce questions off each other.
Yeah, I
Wonderful
agree.
session.
Yeah, you
Really
were such
good.
a big help. Thank you for what you guys provided.
We are always happy to help the other districts. So reach out to us if you need anything.
Thank you. I wrote that down. Perfect. We appreciate it.
Gina, why were you so quiet?
I was having connectivity issues. I know. Sharon's like, that's not like Gina.
All right, guys.
friends.
Thank you
Thank
guys
you.
for taking away.
Thank you.